Well, thank you for that introduction. It's nice to be back here where I've been many times over the years. And you had particularly good weather, although we have it very good at home as well, as you can see. That's a picture of the village where I live and where the Research Foundation is based. And if you ever come visit, please stop by. In any case, I was somewhat taken aback at the topic that I was assigned this year about the severe ME, because it's something that we're all afraid to address. Because number one, very little research has been done for reasons that I'll go on, and it's really somewhat discouraging, but I hope I'll convince you of the hope for the future that's really, I think, right around the corner, and this is about the first year that I can honestly say that. So what I'm going to talk about today is severe MS from the U.S. perspective, a summary of the update of the Health and Human Services programs, a little review of the P2P and the IOM, and then a discussion of those two projects that have been recently published in the United States, because they really have brought worldwide attention to this disease and the importance of it. So the invisible ones, as you say, suffer worldwide. And here's an example from my clinic of several of these patients who fill the criteria for severely affected ME. And you can see they look very similar to the pictures that you showed locally here, with being bedridden, light sensitivity, unable to stand, needing assistance to walk, etc. So a brief history of CFS ME for those of you who don't recall. It's been described for many, many years, largely through outbreaks that occurred with debilitating fatigue, confusion, sleep dysfunction, memory problems, etc. Ramsey coined the term ME a number of years ago, and that's kind of the stage we worked through the 80s. In the 80s and 90s in the US, the focus was on fatigue, both in the definitions and the classifications. And partly that was because of outbreaks that were characterized predominantly by fatigue that occurred. One was in Incline Village, another was in Lyndonville, and the Holmes criteria was established by the CDC in 1988. That focused generally on fatigue and some associated symptoms. It was originally signed an ICD-10 signs and symptoms of malaise and fatigue, and then, as you all probably are aware, the official Fukuda criteria were established in 1994 by the CDC for CFS. And those are still used largely for research purposes. Then in the 90s and up to the present date, we focused more on the neurological, immunological, endocrine, and the post-exertional malaise symptoms. And one of the reasons for that is post-exertional malaise is somewhat unique to chronic fatigue syndrome ME. There's very few diseases that actually get worse with physical or mental exertion. The ICD-10 has put chronic fatigue under a nervous system disease, G93.3, and the US just adopted ICD-10 October 1st of this year. So now the whole world is using the same classification system. The Canadian case criteria was established by a consortium in 2003, and I still think the mistake was calling it the Canadian criteria because it never quite caught on like it should, and it should have been more of an international collaboration. CIVSAC, an interagency committee of HHS, has recommended a number of changes over the years, including adoption of the neurological disorder classification. And then the ME International Consensus Criteria was refined in 2011 and is used by some researchers. As most of you know, the IOM most recently recommended the term systemic exertion intolerance disorder. And I put a question mark because that recommendation has not been accepted by the federal agencies yet, nor any other institution that I'm aware of. And I know that Dr. Jason will be talking extensively about that later today. Prevalence holds about the same depending on what definition you use. US, about 1 million people, 40,000 in Sweden, another number that seems to have held up over the years. Prevalence worldwide, 19 million. And the estimate of 25% of patients are classified as severe, and in a bit I'll show you where that number comes from. But what that means here is that approximately 10,000 people are very similar to those that you saw earlier. And most of those people aren't here today. I'd like to know how many of you, if you're patients, consider yourself in the severe category. Just raise your hand if you think you're in that category. And that's largely because the severe people can't get to a meeting like this. So it's a really invisible, hidden group of people. I totally agree with that nomenclature. So this subset of the population is usually undiagnosed and untreated. And there's a real dilemma here because we really don't know how many there are. This is by guesstimates. This is not by going around and knocking on doors and saying, do you have a homebound person with chronic fatigue syndrome? They have difficulty accessing medical care. Many of these patients I have to go get. We have to transport them in order to get into the office, for example. Another big problem is that they're largely self-diagnosed by a number of criteria, or they've read on the internet or something like that. So to add them into a registry, for example, you would be believing that they thought they had CFS, which makes research very, very difficult. They're largely uninsured, which is probably not a problem in Sweden, but it's a problem in the US, where it would be very difficult getting them evaluated and or treated. We've also proposed that there might be a grant that could do that. And then the cost for the exclusionary criteria is enormous per person that's identified as severe, because you'd have to haul them into the laboratory and into the MRI machine and things like that in order to make the diagnosis. So in short, we really need a special program to assist these kind of patients. And to leave you on an optimistic note, there's a pilot project at Stanford with OMI and Ron Davis and Andy Kogelnick, which is focusing on the severely affected patients. And a recent study by Sonia Marshall focused on the immunological parameters in the severest group of patients. So let's look at the economic loss. $9 billion a year in the US in direct costs. That's office visits and things like that. If you include indirect costs, goes up to about $24 billion a year, making it a very, very costly chronic disease. Or if you translate, depending on the currency exchange, about 200 billion Swedish kroner a year in US numbers. So just a brief overview, you all know this, particularly your sufferers. ME is an acquired chronic multi-system disease with a known genetic predisposition. It's characterized indeed by exertion intolerance, either mental or physical, and the post-exertional malaise. Now, I've taken these new core symptoms from the Institute of Medicine report, in which the core symptoms are fatigue and resulting impairment, post-exertional malaise, unrefreshing sleep, cognitive impairment, orthostatic intolerance, and additional symptoms of pain, immune impairment, and/or infection. Now, the Canadian consensus document, I've just showed this because it's the one that's still used mostly worldwide, both for clinical studies as well as for research. And there's reasons for that. It's a tried and trusted working clinical model. It's been around for a long time. We know how to use it. We know the tools to diagnose, et cetera. And it's still recommended by many in this field. So let's look at severe CFS-ME. Approximately 1/4 of the patients belong to this category of severe or very severe. These patients are bedbound or housebound at present or at some point in their illness. And this is again where it gets complicated, and you'll see in a moment. Most of these patients never return to their pre-illness health, even when they're treated. These patients, I find, are the most difficult, and their prognosis is the most guarded. These homebound patients have a severity of their illness such that they're limited in their access to care. Most of them won't bother going to the emergency room because they say the emergency room doesn't do anything for them. Home visits by physicians and nurses are very difficult to coordinate in the United States, and they're rarely reimbursed, and there's little public funding for that. And treatment options are even more limited. So I agree that researching these patients is of critical importance. These patients may actually demonstrate more to us about this disease than we even suspect because of their severity. On the other hand, they could have a different disease. There could be a reason why they're so severely affected, and that would be very worth finding as well. So the historical classification of severe is very vague in the American literature. For example, an individual that cannot leave their home. Well, there might be many reasons why you couldn't leave your home. An individual that has less than 10% of their prior normal activity level. Now that's a little more specific, but it's still quite vague. Or an individual that cannot come to the physician's office without suffering severe consequences. That's again the post-exertional malaise. Some of these people can sort of get dragged into the office, but then they might be confined to their bed for 2 weeks after that particular visit. So the prognosis of the severely affected. If there's no significant improvement demonstrated within the first 5 years of diagnosis, full recovery is very unlikely. And that's a longitudinal study, epidemiological study by the CDC. Recent long-term follow-up studies cite an increased prevalence of cancer, autoimmune disease, suicide, deconditioning, orthostatic intolerance, and malnutrition in this particular subset of CFS-ME. Now, recently there's been a lot of increased interest, but no increase in funding for studying this very difficult group of patients. So what classes, how do you determine the severe diagnosis? Well, as you know, CFS is a heterogeneous disease and a spectrum of illness. So where along the line there of, are you going to put the line and call people severe versus not severe? It's very arbitrary and very difficult to determine. Furthermore, the illness is not unidirectional. Patients have relapses and remissions and relapses and submissions. Again, a raise of hands, how many of you have that pattern? You do have better times and worse times. Now, how about the people who have only worse times? So, see, it's very difficult to know when to study these people. You study them on a bad day or on a good day or a disabled day. So very few studies have been done. There's a few studies that have been done on good day, bad day, and there's a few studies that have been done checking cytokine levels and hormonal levels every day for a prolonged period of time. And we have some preliminary results on that. And few therapies exist specifically for the severely affected patients. So what about using validated tools? Are there tools we can use that are more helpful than vague things like 10% function? Well, we have a whole bunch of questionnaires that have been used, and most of these are validated and they've been used in other diseases, and they've been used throughout the research of CFS-ME. There's a problem with these, however, in the severely affected, and that's a top effect. When you take the severely affected CFS patients, they can't get sicker on these scales. So you can't follow anything because they're at the max sickness. The PROMIS score, for example, is very useful for people who are not so sick because they can fluctuate. But if you're at the worst of the scale, how can you be worse than worse? So a lot of these scales are not particularly useful for the patients with severe cases. We have fatigue scores as well that have the same problem with scoring and scaling. We have some performance scores, and I'll just show you one of them so you can understand the dilemmas we have in conducting research. Nearly all of these are subjective, of course, but they have been validated in a number of diseases, and one of these is the Karnofsky Performance Status Score. It came from oncology. It came from rating the status of people with cancer before and after treatment and things like that. Most of you are probably familiar with this. It's 0 to 100. It's very reliable. Patients put themselves at the same spot. Physicians who rate the patients rate them the same way. And most of the chronic fatigue patients are about 40, disabled, requiring special care or assistance. But this very sick group is down in the 20s or the 10s, and it's very, very difficult to show any change in persons who are that low on their functional performance. And of course, 0 is 10, and I get these patients who will put themselves down as a 0. Well, they're really not quite dead, but that's, again, the point about scaling of a test. Now, what's interesting about this is that if you change one level, if you go from a 30 to 40, you will describe your quality of life as better. And the FDA has, in fact, licensed drugs that showed only one notch up in performance after the drug versus the placebo. So some of these scales are actually very valid, and we can use them, but they're less than perfect. So the Karnofsky, for example, is not a perfect tool, but it's used extensively and has been validated. Healthcare professionals have to be trained in the proper use, and it's used in interventional and longitudinal studies, even though it's not particularly good for that. And a majority of the severely ill patients will score 40 or below. So what about using something like exercise tolerance with expired gas exchange? There's a big literature now about the use of VO2 max testing to determine disability. And I'm sure most of you are aware of the 2-day test where you do a treadmill with expired gas exchange on the first day, and most of the CFS-ME patients do show a subnormal VO2 max. And on the second day, they demonstrate a marked decrease in their VO2 max, demonstrating the post-exertional malaise correlate. So this can be extremely useful. However, it's impossible to perform this test in this group of patients. They can't bicycle for sometimes 30 seconds, much less 3 or 4 minutes, or they can't walk on a treadmill for 10 minutes. A VO2 max of less than 20 milliliters per kilogram qualifies for federal disability status in the US. So it's a very useful tool for the people who are not so severely affected. A VO2 max of less than 15 milliliters per kilogram defines the very severe disability no matter what disease it is, whether it's heart disease, lung disease, or any other disease. Here's a study that determined that 25% figure in Van Ness, Snell et al. Studied about 200 patients and found that by this objective marker, about 20 of those patients showed a VO2 max of less than 15 milliliters per kilogram per beat, which is compatible by all standards with severe disability, whether, again, that was heart disease or lung disease or whatever it might have been. So there are studies aimed at objective therapies that use VO2 max protocols to identify patient improvement. That's perfectly logical to do that. It's used as an endpoint for several current studies that are now underway in the US. And many of the new interventional studies actually only recruit people based on a low VO2 max. But this is nearly impossible for the severely affected patients to qualify. So they won't qualify for the diagnostic tests, studies, and they won't qualify for the therapeutic ones. So what about tenets of traditional CFS-ME therapy? Does this apply to the severely affected group? Well, number one, it's hard to treat the people in their home, but there are certain things that certainly any physician can do. One of the most important, I think, is hydration. Another is nutrition. Another is appropriate physical therapy, and treat any present pathophysiology. This is just a basic rule of treating people with CFS-ME. I refer any physicians or patients, for that matter, who are interested to the Chronic Fatigue Syndrome ME Primer for Clinical Practitioners that really goes in detail, symptom by symptom by symptom, symptomatic therapies that can be utilized, whether it's drugs or other kinds of intervention, because this basic care applies whether you have a mild, moderate, or severe case of CFS-ME. This is available online. It's easy to download for anybody who wants a copy of the primer. So traditional therapies for the severely ill have been energy conservation. You probably all practice energy conservation or you wouldn't be here today. And that's trying to do more with less work. And there's consultants, there's people who are experts in this field to teach you how to do this. There's pacing practices. It can be extremely useful, doing things at a slower pace, taking a shower from sitting position instead of standing position, etc. We found some success in using things like the Fitbit and the Apple Watch, etc., that can be set for pulse rate, for example. So it will alarm if your pulse rate goes up or your blood pressure goes down. So you can really train yourself to be in the zone. And these little cheap devices, they're like $100 in the United States now, can be very, very helpful for patients and their physicians. And of course, all this information could be electronically transmitted to the physician as well now. So we can see what's going on with these patients at home without having them in the office as far as vital sign monitoring goes. Energy conservation can indeed help patients, but please don't consider it the only therapy. Remember the poor prognosis in untreated. Severely ill patients also develop complications such as bed sores, contractures, deconditioning, secondary depression. We've seen all of this. Autonomic symptoms such as orthostatic intolerance can be disabling. Every time you try to stand up, you get dizzy and lightheaded and have to lie back down. There's targeted therapy that we use, including normal saline infusions 2 to 3 times a week, and you saw a group of patients in my office receiving that therapy. There's midodrine, Florinef. This is one of the most treatable parts of severely disabled people with CFS. Malnutrition is often ignored. It's a last resort to use feeding tubes or parenteral nutrition or something like that. And I tend to start it very early because many of these patients won't eat or can't eat and get secondary nutritional deficits. So here's just a picture of some of the patients, and you'll see I have them monitored. They're monitored at my office, they're monitored at home. They begin, if they do physical therapy, it's very, very simple. It's usually stretching or something like that. It's not jumping on the bike. And they eventually gradually improve so they can do some simple things as the lady on the right demonstrates under supervision. There's some other alternative therapy that's recommended for severely ill patients. They're frequently very sensitive to stimuli. So one of the more helpful things that patients report to me is things like turn off the TV, reduce emitting devices, use protective clothing, reduce trips to a minimal, try to reduce mental and physical stress. But a lot of this is easier said than done, of course. What about drug treatment? Well, many of you have heard about Ampligen, which is the only treatment indicated for severely affected CFS-ME patients in an FDA-approved trial. They recently changed the protocol on this, which may make the drug in the United States more difficult to use. But I have good news for all of you here, because the European Medicine Agency approved the use of the drug in Europe as of April of 2015. So this is a drug that should be available to all of you if you have a convenient, cooperative source of care. Its mechanism of action is a toll-3 receptor agonist that functions as an activator of the immune system, and it has very few side effects. It's been used for 25 years in the US. Natural killer cell function shown to be improved even in the severely affected patients, and it manipulates the immune system as an antiviral as well. It's the only therapy that I'm aware of in my 35 years of practice that has restored people's ability to return to work, skiing, mountain biking, and things like that. I want to bring up anakinra for 2 reasons. One, because it's a cytokine blocker. And there's a lot of research now about dysregulated cytokines in patients with chronic fatigue syndrome. And I think Dr. Horning's going to talk about particularly some findings in the severely affected group. And this is just one I picked out because it's an interleukin-1 receptor agonist. And there's a double-blind placebo-controlled trial that's going on in the Netherlands right now, which should give us some more information. But there's a lot of cytokine blockers that could be used. This one is particularly interesting to me and should be to you because it's distributed by a Swedish company. So it should be available here and is really quite benign. There's no reason not to try something like this. And if it helps, it helps. Rituximab, the world's biggest trial, is going on right now in Norway. And as you all know, its efficacy has been demonstrated and it has some promise. And I'm looking forward to the completion of the trials and the publication so that we know who should be tried on this particular medication. They're also proposing a Cytoxan trial that's in phase 3 trials in Norway right now. So I have some advice for caregivers. One, take time for yourself. Relationships fall apart, as you heard, if you don't protect yourself. Take the help of others out there. You don't have to be the martyr for this disease. There is help available in most communities. Seek the help of professionals who understand the disease. It's a two-way street. You have to compromise continuously with the patient. This is one of my favorite couples because they do a really good job of supporting each other in the process of a very severe disabling illness. And I like the last recommendation. Don't assume that others will ever understand this disease, nor that it's your job to educate them, because you probably can't. So what about hope for the future with respect to the severely affected? Well, I want to share with you the new research from California at Open Medicine Foundation, collaborating with Ron Davis. And it's called the End-ME CFS Project, Biomarker Discovery for the Severely Ill Big Data Study. That's quite a topic, but it describes what he's going to do. And he is attempting to do an identification of biomarkers using big data from multiple tissue samples, in analyzing DNA, RNA, proteins, carbohydrates, and metabolites. And the real point of this is that this is a paradigm shift in research because it's focusing on the molecular biomarkers rather than on symptoms. And what's even more unique with this is that they're recruiting only the severely ill patients to study. What they're going to look at is DNA, RNA, epigenetic markers, proteins, metabolites, and antibodies. A cautionary note about these kind of studies. It's difficult to associate a biomarker with a disease. These studies are extremely expensive, and this is a very small study. So will it be able to extrapolate to the population at large, or only to those 10 or 20 people that are being studied? Small populations make big data analysis difficult, as in GWAS studies, where you need several thousand patients in order to make a determination. And then the specificity and sensitivity, of course, are limited in a study such as this. And that's a precautionary thing for the physicians to watch out for these reports. Now, there's newer technologies that are more cost-effective, and they're coming around, and hopefully we'll see an expansion on this type of research. Phase 1 of this research is funded, and I believe is going to be underway pretty soon. The CDC has year 3 and beyond. It's a 5-year study or longer from Atlanta, Georgia, a multi-site clinical assessment of chronic fatigue. And this is an ongoing analysis of 800 patients at 8 different clinical sites. And they do standardized patient records and administered questionnaires, blood samples, serum biomarkers, saliva samples. And for year 3, this is the first year, we are enrolling 40 severely affected patients. Now, 40 doesn't sound like much for a whole country, but I just told you why it's so difficult to recruit these people. And this is only 5 people per site, and we're having trouble doing it. So it's an enormous problem. The longitudinal data is being compiled by the CDC and analyzed independently. So it has a lot of power because it's 8 different sites. It's not just one site, and I'm looking forward to the results of that study as well. So Sonia Marshall, who some of you are familiar with at Griffith University, does tremendous work in immunology, recently published on her ability to differentiate healthy controls from CFS patients, from severely affected CFS patients, based on their immunological profiles. And I'll just summarize. She found differences in the iNKT cell phenotypes, the CD8 cell markers, NK cell receptors, and the gamma T cells. So this, I think, kind of research may yield a significant amount of information about the immunological dysfunction in this severely affected group of CFS-ME patients, at least in Australia, where they have the resources to outreach because of their sort of socialized medical system. They have the ability to track people in their homes, et cetera. So I think the future may be brighter than we initially might have thought in terms of future research for this very difficult group of patients. So I wanted to briefly tell you about the P2P, the Plan of Action, and the IOM. This is just a summary. These are very extensive documents. The National Institutes of Health has a Pathway to Prevention program, which is kind of interesting, that they want to prevent CFS when we don't even know what it is, but I'm intrigued by the concept. And they were tasked with identifying research gaps, methodological weaknesses, and further research that needed to be done, and specific recommendations for the diagnosis and treatment of CFS-ME. And they did indeed identify gaps, and I'm just outlining some of the ones that I think are most critical. One is the need for a better definition, and they proposed a solution with stakeholders, national and international research, and I underscore that. Why should the disease be defined differently in the United States than Australia, than Canada, than Sweden? It doesn't make any sense, and it's counterproductive to good research. They interestingly point out that it would be useful perhaps to contrast this with Gulf War syndrome, Lyme disease, fibromyalgia, Parkinson's disease, other diseases that share similar symptoms but perhaps are different. And of course, they recommend bench to bedside research, which is called translational medicine. And they suggested doing that through well-funded collaborative centers. Well, lack of funding was identified as probably the #1 stumbling block to better research. Look at poor, struggling CFS down there with many more people suffering than multiple sclerosis, and the funding difference in 15-year budget, $191 million to $4 billion in federal spending. That translates, I think, into why you see the difference in the published peer-reviewed literature. CFS has 5,000 papers approximately. That's not a small amount by any means. MS has 55,000. And even fibromyalgia has about 8,000. They also criticize the methods and measures to assess treatment and identify subgroups. That's basically what I just discussed. They had some solutions, and that's to online tracking tools. Immobile patients should be included. So that was a recommendation of the P2P. Community-based research can be used because it's already in place. It needs to be implemented, similar to what happened in HIV disease. Assess psychiatric comorbidities, and please do long-term longitudinal studies. We don't really know the natural history of the disease. There's a great lack of provider education, and they outlined a number of steps in order to educate physicians particularly. They do recommend more clinical trials. They suggested that perhaps the NIH itself could conduct clinical trials, that the FDA could fast-track trials for which it's so disabling that there's no identified therapy, that we could perhaps repurpose drugs, and that patients needed to participate. They did recommend retirement of the Oxford definition, which I'm sure many of you in this room will agree with, and that we continue multimodal therapies for whatever works for symptomatic relief. Specific recommendations they made were for intensive study of things like GWAS, phenotyping, in order to stratify the patients. These patients aren't all alike, and some of those molecular techniques may be very useful. They underscore the need for a biomarker. We've said that many, many times in a number of years. They advised to employ cutting-edge technology that's available now, and they did interestingly recommend study of the gut biome, which a number of researchers in the United States now have picked up on this and are instituting, and perhaps Dr. Hornig will speak to that later today or during the questions. And I find this interesting. Identify the patients that are at high risk for acquiring CFS-ME, and we don't really know the risk factors. So that's a very interesting question, actually. So they suggest data mining of the databases that are there, more study on cytokines, inflammation, and NK cell dysfunction, because there's a good literature saying that that's a key to this disease process. The obvious is to do more studies on twins for gene expression, et cetera. And then to understand the effects of complementary and alternative medical treatments that patients feel are useful, because there may be clues as to why those particular therapies are useful. And then lastly, establish a national biobank to house results. We have a number of biobanks that are in existence now, but they're not exactly collaborating yet. And one of the big issues is, what do we do with people who wish to donate their body parts and perhaps their whole body to research? That's a very difficult topic. It sounds easy, but it's really not. It's a complete book. If you don't want to read the book, there's a synopsis of the book that's readily available. And they were examining evidence-based history to propose new diagnostic criteria in order to allow more timely diagnosis, enhance care, and enhance understanding. Laudable goals. And I'm just summarizing because this is readily available to anybody who's interested. But they created a diagnostic algorithm for ME/CFS that is very simple, that takes about 3 minutes and can be done in anybody's office, a nurse practitioner, a PA, or anyone. And they made 4 key recommendations: that any physician should be able to diagnose this. And in their publications, they've got guidelines for how to do it that are more extensive than their little summary diagram. They developed a standardized toolkit for screening and diagnosing these patients. The diagnostic criteria should be re-examined at least every 5 years. This is a point I disagree with, because we're wasting time waiting another 5 years. This should be an ongoing process. It should be evaluated much more frequently. And then their most controversial recommendation was to replace the name ME/CFS with systemic exertion intolerance disease. So overall impressions of the IOM: it's a very respected organization. It's like without repute in the United States. What they say is the truth. So they made a very strong statement about the severity of the illness and the realness of the illness. They also reported extensive literature review. And if you want to know anything about the literature and the quality of the literature in this disease, go to this document, because it's all in the document. They proposed new diagnostic criteria. They did say it needed to be validated and compared to previous diagnostic criteria, and I know Dr. Jason will be addressing this. There were few IOM members from outside of the United States, so it's unclear whether this will be widely accepted elsewhere in the than other in the United States. The other problems is that subgrouping is not possible. Comorbidities are allowed, so there's some difficulties with some of their suggestions. But it's been widely publicized, obviously. The HHS Chronic Fatigue Advisory Committee, which meets a couple times a year, just published their recommendations that put together the IOM and the P2P. And that's available online as well. This was published in August of 2015. And I just want to summarize. They broke their report down into 4 categories. And I just want to briefly talk to you about research direction, funding, and goals. So their research funding, directing, and goals prioritize biomarkers, address gaps, advance treatment, standardize assessment, assign the disease to an institute, and appoint an agency leader. So both IOM and P2P identified evidence of biological dysfunction. So the recommendation is to follow up what's already been started and already been reported, and look more intensively at functional MRI, PET scanning, 2-day VO2 max testing, cytokine profiling, gene expression, metabolic studies, and K-cell function, and all other promised markers. While the evidence was fairly good that some of these things can be useful, it wasn't good enough to say it met evidence-based criteria. Address gaps in the translational epidemiological research. They suggested that NIH fund and CDC allocate targeted funding to fill the gaps that were identified previously. Updated epidemiological studies are needed, especially on severity of illness, especially about the group of patients we're talking about right now. Currently, there are large data sets exist. They could be utilized and studied, saving time and money in this process. They recommended that the NIH could make resources available for repurposing drugs or even studying new drugs. This is not the role of the NIH, but they do have the capacity to do it. And that they can also trust existing clinical centers of excellence or establish new centers of excellence to speed along the process. Standardized assessment methods, of course, this is a requirement. This is one of the reasons that the research has been less quality than originally any of us desired. And they do suggest using the 2003 Canadian consensus criteria until better research case definitions are established. And of course, again, they advised including stakeholders, clinicians, et cetera, operationalize things. We're all looking for those sorts of things these days in medicine, how to do things in a uniform manner and how to do it properly. Assigning the disease to an institute, probably you in Sweden don't realize this, but CFS-ME has been relegated to the Department of Women's Health for all these years, which did not have a designated budget nor a particular interest in this disease. So it was recommended that it be moved either to the National Institute of Neurological Disorders and Stroke or to the Institute of Allergy and Infectious Diseases, where it would have a standing committee for funding, et cetera. And certainly, I think most people who are in this field support that recommendation. They also suggested an agency leader or a czar of the disease, as has been pointed in some other diseases. And it's an interesting concept. I just don't know who would do it, because someone would have to be very enthusiastic, talented, young, energetic, and thick-skinned to take that position. So all this leads us to a call to action. The impact of the P2P and the IOM has focused attention on the seriousness, particularly of the severely disabled patients. And it's really fertile ground for something to be done now. The IOM establishes strategies to do this. They have a lengthy section on how to get the information out to school nurses and psychologists and physicians and medical students, et cetera. Centers to determine the specifics of diagnostic and prognostic markers. And again, the biggest criticism is that the clinical trials have been compromised. They're small and heterogeneous, and they need to be redone, and I agree with that. So there's a bottom line here, though, that I want to emphasize. Much research really needs to be done. Little funding results in little research, which results in little evidence, which results in no evidence for further funding. So it's a really vicious cycle that this particular disease is in right now. So as a summary, I think these reports are marvelous. I'm glad they were done. I'm glad they were done promptly. And I think that they should be leveraged, not killed. There are defects in both reports. There's no question about it. But they're positive, and they're positive for the patients as well as for research. CDC, for example, removed its toolkit. They're waiting to make new recommendations based on these two documents. But I think reorganization of the ME-CFS effort is required, and I think it should be international. I don't think any country should take a position that we know everything about CFS-ME and the way we do it is right. And I think the most salient things that need to be done are adequate research funding, collaborative networks, centers for excellence, grant money, validated outcome measures, and perhaps the most important is physician education. So I thank you very much and look forward to our discussion later in the day.
Could you please tell us a bit more about Amplien treatment?
It's been used since 1988 for chronic fatigue syndrome in the United States. Its drawback is that it's very expensive, and it takes some experience to know how to utilize the drug correctly. But the response rate is about 70% of the patients in the trials have had significant responses, including some return to their normal state of health. And what I mean by that is working full-time, going to school full-time, skiing, mountain biking, things like that.
Thank you, Dr. Peterson. Warm hand again. Thank you.